Patient comes to you complaining of shortness of breath, and then you listen to them and you feel that they've got some decreased breath sounds in the bases, and then you get a chest x-ray and then you see the patient's got fluid in the lungs. What are we dealing with? A pleural effusion. Okay, so when it comes to a pleural effusion, when you see a patient and the patient's got a pleural effusion, first question for you, are you going to do a therapeutic thoracentesis? Well, I'm talking about a therapeutic. There's a difference between a diagnostic thoracentesis versus a therapeutic. Therapeutic is you're doing to remove a large volume to relieve them of symptoms. So is a therapeutic thoracentesis indicated? Answer is no. You do a therapeutic thoracentesis if the patient is, I want to hear just one word, symptomatic, period, done, that's it, okay, symptomatic. Even if it was ascites, if somebody comes with a massive belly and they got ascites, does every single person require therapeutic paracentesis? No, I want to hear one word, if they are symptomatic. Diagnostic is a whole different question. Every single patient who comes to the first time pleural effusion, do they require a diagnostic tap?
Yes.
Yes, you must get a diagnostic tap. Okay, so you're going to do a diagnostic tap, and what are you going to do with this fluid? So you're going to get some fluid out and you're going to send it to the lab, and what are you going to calculate?
Lights criteria.
Lights criteria, very good. What are the three things we need for the lights criteria?
LDH, protein.
You're going to need protein, LDH,
pH.
you don't need pH, so it's protein, LDH. So what is the criteria? Protein, you're doing a pleural protein is to serum protein. The ratio should be greater than 0.5. LDH, plural, is to serum LDH should be greater than 0.6. And your third criteria is your pleural LDH is greater than 2/3 the upper limit of normal. Okay? 2/3 the upper limit of normal. How many of these criteria do you need to define it as what? You need one criteria to call it exudative. Very good. Now, when you think of exudative, what are the conditions that falls into exudative and what are the conditions that falls into transudative? Tell me transudative first, because it's pretty easy. All your failures, heart failure, liver failure, kidney failure, done. Okay, heart failure, liver failure, and kidney failure. What about exudative? You'll have infection, okay, infection, inflammation, what else? Cancer. Basically, these are your three main types: infection, inflammation, and cancer. Okay, so everybody who comes with the pleural effusion, you must do a diagnostic to diagnose it. Now, is lights criteria good? It's good for exudative. It's not very good for transudative. You have to take your lights criteria with a big grain of salt. A lot of things can actually affect it. Like what? All right. So when you think of exudative, you always have a big concern for infection. Okay. Now when it comes to infection, what is going to be unique on your pleural fluid that you specifically need to order to see and say, hey, this is definitely infectious? Huh? Glucose, very good. You want to get a glucose level, very good. What else? And what would your glucose be? Typically for an infection should be less than 30. Okay? If you have less than 30, it's highly indicative of an infection. Why? Because bacteria love sugar, just like all of us humans. Huh? Yeah. For bacterial infection, yes. So you want glucose to be less than 30. What else?
pH.
pH, very good. pH needs to be less than 7.2. Very good. So if you have a pH less than 7.2 and a glucose less than 30, it is highly indicative of an infection. But what else are you going to get to say, hey, this is an infection? You want to see the WBC, and what kind of predominance are you going to see here? Neutrophils, very good. You'll see neutrophil predominant because neutrophil is predominantly going to fight a bacterial infection, right? Okay, what about gram stain? Yes, you want to get a gram stain, right? Gram stain and culture you need, right? You need a gram stain and culture and it will tell you if the infection is present. But even if the gram stain is negative and the culture is negative, still based on these parameters, it still indicates infection. Let me ask you this. What if you had glucose less than 30, a pH less than 7.2, but instead of blood neutrophil, you have predominantly lymphocytes? What could mimic an infection, but it's actually not an infection, it is a lymphocyte predominant? Rheumatoid, very good. Patient with rheumatoid arthritis can develop pleural effusion, which can essentially mimic an infectious effusion. But the difference is going to be that you're going to have a lymphocyte predominant. So they can easily confuse you with that. Yes?
So you need all three
For?
to say that it's an
Yes.
infectious process?
Yes. You need a pH less than 7.2, a glucose less than 30, and a neutrophil predominant.
No, I was going to say TB also goes lymphocytes, but...
Very good. Now TB is a whole... So another important thing that can also mimic this exact same picture is going to be tuberculosis. Okay? But TB again is going to have more of a lymphocyte predominance. Okay? So, but in order for you to say TB, now if somebody's got rheumatoid, will know the history of rheumatoid. A lot of people could have TB, but sometimes you never know, right? And if you're suspecting TB, how are you really going to make the diagnosis of TB? Because for TB, you really have to prove it now. So what are you going to do? Are you going to do a stain to see acid-fast bacilli? You can do that, or you can do a culture, right? How sensitive are these tests? To rely on the pleural fluid for acid-fast bacilli stain, it's actually very, very low sensitivity. And a culture takes 5-6 weeks and it's very low sensitivity. So what test are you going to order on that fluid which has 90% sensitivity? A lab test. You ordered that, you got your answer. The answer is ADA, adenosine deaminase. Very good. Adenosine deaminase is what you're going to do. Pretty much most patients with TB fluid will actually have adenosine deaminase positive, so 90% sensitivity. If that is negative, you can essentially rule out. You can rely on acid-fast bacilli and cultures to rule out TB. Okay? Alright. Now, sometimes you can have patients with malignancy that you know of. Right? Say the patient's already got an inherent lung cancer or pancreatic cancer with mets of the lungs, right? And they develop pleural fluid. You always have that suspicion saying, hey, is this a malignant effusion? So you get the fluid, do Light's criteria, it's going to be exudative pattern. And typically what you're going to look for is cytology, right? The cytology is going to tell you if malignant cells are present in the fluid or not. And that'll give you the answer. What if it doesn't? And you're like, hey, you know what? I think this is still malignancy related. But the cytology is negative. Huh? Say you tapped him again, still cytology negative. Tap it again, cytology negative. 3 taps.
That's 30%.
Something else.
Scan.
Huh?
Scan.
You've already got a scan, there's no lesions anywhere. You will do a thoracoscopy, okay? Put a camera in and you will do a pleural biopsy, okay? Put a camera into the pleural space and look for yourself and you'll do a biopsy of the pleura. If you're suspecting a malignant effusion, go for a pleural biopsy. And if not a blind biopsy, because you don't know what you're biopsying. So you have to put a camera into the pleural space and biopsy specifically whatever you see. Because you'll typically see some thickening. Okay? So that's going to be your answer for malignant effusion. Alright? So when it comes to pleural effusion, you must know your Light's criteria and know the problems that can happen. But if you know all of this, you should be good enough. Now, if somebody's got an infectious, let's put it this way. If somebody's got an exudative effusion, you did a diagnostic tap only, right? Say if it's inflammation, you're like, alright, I don't need to get all of it out. What if it's an infection? Do you have to go for a therapeutic thoracentesis? It's an infection. It's an infection.
If it
grows
It's an
bacteria.
infection. What is the number one rule in an infection? Source control. So if you have an exudative effusion, that is an infection. Okay? If it's present with gram stain and cultures telling you yes, the patient's got an infection in there, you want to drain it. Therapeutic thoracentesis must be done. Okay? You do a chest tube and you remove all the fluid, give antibiotics and get rid of it. You can't have sores sitting around. Sometimes, when you let the infection sit for too long, what's going to happen? That effusion, which is accumulating, is going to form something we call loculations. Okay? You're going to have loculated effusion forming multiple pockets. Now, you've run into a much bigger problem because you let it sit there for too long. What are you going to do now? Number one question, does this need to come out? Absolutely, it needs to come out. So you do a chest tube, but is a chest tube alone going to get all this stuff out? It's not. You need to give some medicines to break all of this stuff up and suck it out. What medicine do we give?
DNAs.
You will give DNAase, very good, and intrapleural TPA. So intrapleural TPA and DNAase you'll give and basically break everything up and suck it all out. Okay? You have to get everything out if there is an infection. That is gold standard. Alright? Okay. Say you do intrapleural TPA and DNAase and you're like, you know what, everything's not coming out, the lungs are not expanding, it's still accumulated, what are you going to do for next? Now, when you are going to do a therapeutic thoracentesis, okay, say you do a chest tube, how much volume do you want to remove? Or say you're doing a thoracentesis and you want to just, don't want to leave a chest tube in, you want to remove fluid. How much fluid should you remove in a given setting?
Maximum 2 liters.
No more than a liter. Yes, so no more than 1 to 2 liters. Don't remove more than 1 to 2 liters. Why? What are you worried about?